Good afternoon, everybody. Lunch and Learn, Friday, May 10th. As you know, today we have a guest speaker, Rob Coben. You've read his brief bio. What I would say to you is I had the fortune of working with Rob as a board of directors of ISNR member, board member. He was president when I think I came in, or he was within the second year I was on the board. And so really enjoyed working with Rob. And one of the things you may not know about him, and he can tell you about this towards the end, is he and his wife, Ann, also do health coaching. So he's been doing that as well as all this work about neurofeedback and coherence. So without any further delay, I'm going to turn it over to you, Rob. Thank you so much for being here with us, and it's all yours.
All right. That's a great introduction. Thank you. And thank you all for attending and listening here. I think we're already sharing the screen here. So
yep, we see your PowerPoint.
Okay, great. I'm a neuropsychologist. I've been a licensed psychologist in the state of New York and now Arkansas. I've had a practice doing neurofeedback since about 2000, so almost 20 years now. And I've probably been doing coherence training type of neurofeedback for almost 15 years. And about 6 years ago, we created with some engineers a different type of doing coherence training. So we'll talk about that today. Okay, so why don't we get rolling here? All right. So one of the things we need to understand if we're talking about coherence training, and for those of you that are new to this concept, the basic idea of coherence training is that it's a little bit different than amplitude or power training, which just obviously, as you all know, trains the size and shape of the waves and the amplitudes of them and on all of that. What coherence training does is it trains for communication patterns between the sensors where you're doing your training. This is quite a bit different than just doing the amplitude or power training, and has differential effects as well, as we'll talk about in a little bit. So in 2014, with two colleagues, one of which is a UCLA neuroscience professor, and the third, Rex Cannon, who hopefully some of you know about in the field of neurofeedback. He's also a past president of ISNR, and he's actually the editor of the Neuroregulation Journal. We published a paper looking at different methods of looking at coherence or connectivity in autism. This was published in Frontiers in Human Neuroscience. This is a freely available open source article. So anyone that would like this, you just go to the Frontiers in Human Neuroscience website, or to the link on here, or honestly, if you just Google Coben Coherence Autism, I think it's the first thing that pops up. And you can download this and read it. It's also on our website, which I'll give you towards the end of this talk. This article has been downloaded and read by about 25,000 people throughout the world. So it's been kind of an interesting experience for the Frontiers. The Frontiers Journal keeps track of those things and where the people are in the world and all that. So it's kind of fascinating stuff. The algorithm for coherence, which you see as number 1 here, has existed since the early 70s when it was first created by mathematicians working in other fields, mainly engineering, and then applying it to EEG data. And basically what it does is it takes the cross power spectral density of 2 locations in the brain, squares that value, and divides it by the power spectral densities of one multiplied by the other. What does that mean? Coherence basically is the similarity, that's sort of like a correlation matrix, the similarity in 2 waves formed from 2 different locations within a given frequency band. So it tells you that they're doing similar things at similar times, essentially. And because you see that in the denominator, what it does is it removes amplitude from the equation. So what that does is it prevents changes in amplitude by itself affecting changes in coherence. So coherence now is a more pure measure of similarity in these waveforms than other things are, like co-modulation or similarity is another measurement, or spectral correlation is another measurement. They all include amplitude in their equations. But early on in the calculation of this, which is why you see a sort of a second calculation down here, it was realized that in the coherence equation, there's actually some error built into this equation. And what was created is this idea of a real co-spectrum that is a real covariation between those locations, and what's called an imaginary co-spectrum. And that is data that enters the equation that is actually has nothing to do with what's happening at those two electrode sites. And most people believe that that imaginary spectra occurs as a result of what's called volume conduction. So volume conduction, for those who don't know about this, is basically the idea that you can have activity that generates from deeper brain structures, comes up to the surface of the brain, and affects multiple surface locations all at once. And if you're just measuring the coherence between those locations, you're getting a lot of things in those measurements that aren't just the relationship between those two sites. So it was believed that that's what happens here. So for probably about the last 15 years, we've understood that when you measure coherence in pairs, there's error built into that calculation. We'll talk more about that in a little bit. But in terms of coherence training as a neurofeedback approach, this was started about 18 years ago by some very preeminent workers in the field. Joseph Horvath is no longer with us, unfortunately, Jonathan Walker, Kurt Thornton, who are. And they all attempted to look at this in persons with closed head injury. For those of you that know anything about the research in this topic, in traumatic brain injury, connectivity problems are paramount, and they're probably the biggest problems that occur after head injury in terms of brain function. And they use coherence training to train coherence up to get their brains to function at higher levels and reduce symptoms. So here you see some of the work of Kurt Thornton, who was the first to publish in this area in the Journal of Head Trauma Rehabilitation in the year 2000, so 19 years ago, where he took a series of case studies and he picked a couple locations. Hopefully you can see that on these little head maps down here. And he trained within given frequency bands, for him usually alpha or beta, and trained up coherence between those locations. And what he found is when he did that, they were able to accomplish that. You can see the graphs going up. So there you see a learning curve where they were able to train their coherences to rise, get stronger. And as a result, their memories improved, reading abilities improved, lots of other things improved along with that. So that was the first demonstration that you could actually do this, what's called a feasibility study, and that it could have a benefit to those patients. Jonathan Walker and colleagues published 2 years later in the Journal of Neurotherapy, where they looked at different combinations of electrode pairings in people with head injury and found very similar results, that if you train across these areas, that you get decreases in symptoms. And they showed a global improvement of about 72% in somewhere on the average of about 20 sessions. So that was very, very encouraging as well. Dr. Walker has since that time demonstrated the use of this in dyslexia and in seizure disorders, also in migraines, in emotional regulation areas, very interesting areas of practice, which those of us that do research in this area have picked up on his initial demonstrations and have worked on this more intensively. But he was definitely the originator. Here you see a neuroscience study that's taken on this idea, published in Clinical Neurophysiology in 2014, where they took stroke patients and they trained coherence between motor cortex areas that you can see in yellow down here. And again, they were able to show that in and across sessions, coherences would rise. So each colored line is a session and the session duration. You can see that it's rising every single session. And if you actually do coherence training, depending on what system you're working in, you can monitor this across your session as well and see that happen. And what they found over the course of their training, which was only 7 sessions long, is motoric improvement in people that previously had hemiparesis from strokes. So very encouraging again. We published a study in neuroregulation in 2015 using this to treat dyslexia, where we trained 2 locations over the left hemisphere. For us, this is always guided by a QEEG and coherence measurements, which we'll get into a little bit here. But these lines you see here typically show 1 location over temporal, parietal, occipital sites, and another one over temporal, maybe anterior parietal or posterior frontal regions. And we did this with 21 subjects. We had 21 subjects who were also in a comparison group that just had resource room training for their reading problems. And we showed a very significant difference between the trainings. And in fact, over 20 sessions showed there was an average of 1.2 grade level improvements in reading scores from doing the neurofeedback. I'll tell you, there's no other reading intervention that can accomplish that. So that was really exciting to be able to see that. Interestingly, I have a friend and colleague in the Netherlands, Martijn Ange, who did a similar study with dyslexia based on their QEEG measurement, and I'll tell you the difference in a second. They did not find coherence problems in their dyslexic subjects related to reading problems. And when they trained according to what they found, which was hypercoherence over the right frontal lobe, they didn't get any improvements in reading scores. So one of the challenges there is that the way you look at coherence and the way you measure it makes a difference in your assessment and what you receive. So what you see on the top line here is coherence measured in the NeuroGuide QEEG system. This could be in virtually any QEEG system, including BrainDX, which is the current version of NX-Link. For any of you that are familiar with these, the HBI database is similar. They all look at coherence in pairs. So they take 1 location, they take a second location, they measure the coherence value between them, and they compare them to a database. You're going to see in a minute how that is problematic and gives us partially invalid results. That's what the group in the Netherlands did when they looked at their dyslexia data. And they did not get the same low coherences we found in our data. The coherence metric on the bottom half of this graph is through a program called NeuroRep, which looks at coherences by comparing every combination of interactions between all 19 electrode sites. So it's not just 2 at a time. It's what we call multivariate coherence. And what you can see here is, if I can highlight this, nope. Anyway, hopefully you can see my mouse. Let me get rid of this. And basically, you see these spaces on the left side, how they're stretched out. Those are areas indicative of low coherences. So those would show temporal parietal up through temporal and frontal regions, and delta, theta, even alpha and beta to some degree, but delta and theta are more significant. So we would then train across those areas. If you look at the comparisons above, those are not indicated at all on this coherence analysis. So you get completely different results, and you would do completely different training based on what you get out of this. So how you look at it is very, very important. Next slide. Okay. So we've also looked at this. For any of you know our work, we've done a lot of work in autism. And this was a comparison study published in 2010, where we looked at data from some Betty Jurashevitz, who did a study in 2012, the first study in autism, to look at power training, where they did get significant improvements, but comparing it to our coherence training, there was about a 2 to 3 times greater efficacy and outcome as a result. So this type of training does in fact make a difference. For any of you that want to read about all the research that's has been done in that area, this is a book that we edited. I think it was published in 2011 at this point, yeah. And this was a book that we authored, a chapter that we authored within that book. The chapter can also be found on our website if you want to get that without getting the book. So there are different ways of looking at connectivity and coherence. When we look at connectivity, we talk about structural connectivity, functional connectivity, and effective connectivity. So structural connectivity essentially refers to what are the actual pathways in the brain. This is measured these days through something called diffusion tensor imaging, which is this image on the top right, where we can actually look at the transfer of water molecules across brain regions through MRI technology. It's the only way we know of actually looking at this in a live functioning person. The next line below is what we call functional connectivity. This is what our pairwise EEG measurements are. And this is what we're saying leads to some error rates at times because it doesn't really emulate the actual structural connectivity. There is then what we call effective connectivity, where you can actually use advanced statistical procedures that will calculate the combination of every electrode or source of electrodes in calculating connectivity, or what we call causality, where we can actually show what's happening at one site causes what happens at another site. Just like you would do a multiple regression, you can do this on multiple inputs in the EEG. This takes very sophisticated mathematical analyses, but it can be done. And we process all of our data like this now and can do that for other people as well, or show you how to do that. The goal is to get to effective connectivity. Because in effective connectivity, you get rid of these on our practice, a 12-year-old girl with autism. And on the right-hand side, you see a normal control that shows a very beautiful pathway going from their prefrontal cortex down to the temporal and limbic structures that help them regulate social processes in their brain. This is what's called a mirror neuron dysfunction, for any of you that are familiar with this. Well, in our 12-year-old patient, you can see her pathway looks a whole lot different. And that's the dysfunction that occurs in her brain that makes it difficult for her to process all of this information. So the same day we had her do this MRI, she came in and did an EEG in our office. And in that EEG, we should see coherence problems across that right hemisphere from frontal to temporal regions where this pathway should occur. And in fact, in the pairwise metrics down below, we don't see that. There is no pathway along that right hemisphere from front to back that stands out. Whereas again, in the multivariate calculation, there is. You see that space all along, the separation all along the right hemisphere where we see that. Again, if we were to train using neurofeedback and coherence training based on the top one, that's where we would train. Based on the bottom one, we wouldn't. So it's very important to look at this data in the right way. Actually in 2004, the first study that demonstrated the difference between pairwise and multivariate coherence was published by a group, I think out of Germany. This is a review they published in 2011. And basically what it shows is they did a EEG simulation where they had 5 EEG coming from 5 locations, and they could predetermine the connections. So their EEG showed a path from 1 to 2, 1 to 3, 1 to 4, and 1 to 5, and that was it. Those are the only pathways involved in their connections. And what they did is they took all 5 locations, they measured the pairwise coherence between all 5, created a correlation matrix, multiple regression we've talked about using between all 5 locations, and then came up with the connections. And you're going to notice the results are very, very different statistically. And what they found is that in the bivariate calculation, because of the error and redundancy built into that, you get these black lines from 1 to 2, 1 to 3, 1 to 4, 1 to 5. Those are the actual connections. That's good. That's what we want to see. But you also get these red lines, which are connections or relationships that show up that don't actually exist in the EEG of this person. That's very important, because these red lines now are what they refer to as spurious connections. That means they're connections that show in the data, but they don't actually exist in the person. And we're left now to decide which one of these do we focus on for their treatment. Well, we don't know the answer to that because they're not black and red when we get this result. We just need to guess which one is the most important one, versus this multivariate approach where you only get the real connections. And it really is that discrete in real life. When you look at an actual EEG of someone and you can parse it down to these important connections, you can see these differences. We've done this on hundreds of people, where pairwise coherences, again, give you these spurious connections in about 50% of the cases at least, and the multivariate calculations really do not. So again, it's very important to move in the direction of making those calculations. So in 2014, I'm sorry if I'm going really fast, there's just a lot to get to here, and I want to save some time for questions at the end. In 2014, we published our first article where we showed the demonstration of this technique, which is called Granger causality. Granger causality is the mathematical measurement used to do this causality or autoregressive technique, where you can take the sources of the EEG and measure direct causality or connectivity between these regions. So we compared this to pairwise measurements, to S-Loretta coherence measurement. So even taking the source but still being pairwise gave us error rates, whereas the Granger causality those direct causality connectivity measurements did not. So that is what we use on all of our patients now. Here's one more example of an individual with depression. So what do you expect to see in depression? We talk a lot about, in the field, we talk a lot about frontal asymmetry, alpha asymmetry in depression. But there are some flaws in that research. And what current research is showing us is that in the left frontotemporal limbic regions, you almost always see connectivity anomalies and decreased activation. So this is a PET scan that shows you decreased activation of the left frontal and limbic regions of the brain. And then in fMRI, you see the same regions. And these magenta lines show connectivity abnormalities in different studies of connectivity in major depression. So that's where we expect to see the problem. This is an individual with major depression. Again, our pairwise coherences up above do not show those problems over the left hemisphere, whereas our multivariate coherence does, and our Granger causality below clearly does. The way you interpret this is the dark blue lines show you the connectivity anomalies or low connectivity across these regions. So you'd see an area over the left frontal temporal limbic regions that would need to be trained to enhance coherence within these given frequencies to alleviate their depression. And you'll see later this technique works very well for treating depression. But that's the basic idea. You do a full EEG at a minimum of 19 channels, a QEEG. We can then process this data in this Granger causality approach to get these connectivity metrics, and then work with people to show you what areas to train in terms of coherence so that you can train those areas of the brain. So about 6 years ago, we developed a model of doing what's called multivariate coherence training, which is what we use now. And this is the first article published on that. Again, this was published in Frontiers in Neuroscience in their Neural Technology journal. Again, this is, I think, at this point been downloaded by a few thousand people. This was just published last year in the fall. Again, you can freely access this. You can get this from our website or from the online version as well. And what we did is we did a study of about 174 subjects where we did 4-channel coherence training, which I'll explain to you what that is in a moment, compared to regular 2-channel coherence training. And what we found is that the 4-channel coherence training was more efficient. That basically in the same time period, it had double the effect in terms of training power, which is what you see on the graph on the left. So the 4-channel training reduced amplitude or power at double the rate the 2-channel training did. And you'll understand why in a moment when I explain to you how the therapy actually works. And in terms of actually training coherence, 4-channel coherence versus 2-channel coherence changes it by about 400%. So the amount of change you get is quite significant. So in this model of training coherence, you have 4 sensor locations. So obviously you need to be using an amplifier and an EEG system that gives you 4 independent channels, that sensors you can place on the head. They are then trained and calculated in a multivariate fashion. So you take a pairwise coherence metric to every combination of these, and then you average all of them, which gives you a single value that you can train up in your reward band. So your reward band picks a frequency band, picks the 4 locations, trains up across these 4 to train to increase coherence, and it's the average of all of these that get trained over time. At the same time, you have 2 to 3 amplitude inhibits that average the amplitudes across these 4 locations and down trains those amplitudes. So basically what you're doing in this therapy is you're usually increasing coherence. You can also decrease coherence, but by and large for most people we're increasing it. I would say at least 90% of the people that do this. And then you're also doing power training by decreasing amplitudes. So it's a combination of coherence and amplitude training you do simultaneously. So the primary metric we use for this is called QPS average. This is programmed into several different neurofeedback platforms at this point. And if you want to know more about that, I'd be happy to answer those questions, where you can find that. But basically that's how it's done. And we've done this now with hundreds to probably over 1,000 different participants, patients, subjects in research studies, people in clinical practices. We've done it in our own practices. We've done it in practices we consult with, probably 30 to 40 to 50 different practices across the country and the world that have implemented this and have found similar successes across a wide range of difficulties. So in terms of diagnoses, this is a listing of some of the people that have been helped with this approach. And generally speaking, if there's a group that has, connectivity or coherence problems, they can be aided by this approach. And, for my money, that's pretty much everyone that we work with. But there certainly could be people that that's not, the key to it. I would add migraines to this, where there's a significant connectivity piece. I haven't added that to the slide yet, but it can help lots of different types of people. In the past 5 to 6 years, we've done 1, 2, 3, 4, 5, 6, 7, 8, actually 9 different research studies looking at this. We'll talk about some of them in a moment. In total, that has included about 600 different subjects, and they've all shown that the 4-channel approach has greater efficacy than either another type of neurofeedback, whether it be 2-channel coherence training or single-channel amplitude training, or different types of alternative treatment. So it's shown to be very successful in helping people not only change their EEG, but reduce their symptoms. And of course, you have people with traumatic brain injury, seizure disorders, learning disabilities, autism, depression, developmental trauma, and others. So this is, I'm just going to give you a quick sampling of some of the groups that we've worked with. So this was a study on dyslexia, but also use other types of learning disabilities, where we found 4-channel training in the same time period increases reading scores by 1.6 grade levels, whereas if you remember, we talked about the 2-channel training doing 1.2. So there is a greater efficacy level. And the graph on the right shows us that 16 out of 21 subjects improved by at least 1 month every session, whereas in the 2-channel training group, it was only 5 out of 21. So not only does it have a greater efficacy, it's more potent in terms of helping people change, but it helps a greater number of people make that change as well. This was our TBI study that was done 2 years ago now, where we showed significant improvements in neuropsychological testing and in reporting of symptoms, pretty much to normal levels in most people, or very close to it, over a period of time. And what was studied in this project, which was very interesting, was, does time since the TBI matter in the training? Because in most rehab circles, they say, oh, you only have a year or 2 to work with someone with a TBI. Well, we worked with people 5, 10 years post-TBI in this study, and we grouped them based on less than a year, 1 to 5 years, and more than 10 years since their injury, and it didn't make any difference in their outcome. So no matter when you've had your TBI, you can use this approach and still improve. A study on seizure disorders showed that if you compared the 4-channel training approach to the typical SMR training approach that most people use with seizures, which is of course effective, it helps about 50, it shows about a 50% reduction in seizure rate over an average of about 40 sessions. Our 4-channel coherence group, again, this is only one study, and needs to be replicated, but there was an 81% reduction in seizure events using that approach. So we think there's lots of potential to be accessed there. This was a study of autism, comparing the 4-channel training, which is the group in green, to the 2-channel coherence training, the group in blue, which is the work we had done previously. And you can see in every measurement, the 4-channel group does much better. If you ask parents how much did your child improve or not improve, in the 2-channel group, about 80 to 83% said yes. In the 4-channel group, it's about 98%. So again, we get a greater improvement. It happens faster, it's more efficient, and a greater number of people seem to show that improvement as well. To the point where honestly, there's very few people that don't show improvement. Now, of course, there are always going to be some people that don't respond to training, and that's unfortunate, but this helps us reduce those numbers dramatically. In most typical research of SMR training or power training or theta beta training, that's single channel, typically you get anywhere between about a 65 and 75% response rate. We're talking about 98% in this group. And this is our depression study, which in my mind is one of the most impressive. And in this study, what we did is we randomized the subjects to the neurofeedback group that got the 4-channel training, to a psychotherapy group that received psychotherapy only, and to a waitlist control group that didn't receive any intervention. And what you can see is that when you compare the 3 groups on self-rated depression, so they filled out the Beck Depression Inventory before and after, they got training over about 2 months and therapy over 2 months and waited over a 2-month period of time. The people that did the neurofeedback reduced their Beck Depression Inventory by an average of about 26 points. For any of you that have worked with this scale, this is a very significant rate of improvement. So you're talking about going from a BDI of about 40 down to 14 or so. The psychotherapy group decreased it by only about 7 points. The waitlist control group by about 5 points. So you can see that that difference is highly significant. And here's the, again, the percentage of people in the groups. There was 18 subjects in each group that improved by at least 1 standard deviation. In the therapy and waitlist control group, only 7 out of 18. In the coherence training group, about 16 to 17 out of 18 did. So again, same pattern. We see greater improvements, and we see a greater number of people benefiting as well, almost the entire group. What we then did is we took the people that were in the waitlist control group and we did a crossover study. So we said, okay, now we're going to give you the neurofeedback, and we studied their response to that. So that's this right here. So the waitlist control group, this is a T-score of their Beck Depression score. When they weighted, they went from an 85 to an 82. For any of you that know about T-scores, there's a mean of 50 and a standard deviation of 10. So anything above a 70 is significant. That would be 2 standard deviations above the mean. So they still have significant depression. They then did the neurofeedback. They went from about an 82 down to a 64. So again, that diminished their depression significantly. When we then did a follow-up 2 years later, their depression was still in the normal range, or in other words, they were trained to have very diminished rates of depression, and that stabilized without treatment afterwards, so that the treatment effects last. You see that here on the group on the left, which is the neurofeedback group in blue, where they trained, and then 2 years later at follow-up, they stabilized. So we see not only the treatment effect and a replication of that treatment effect, but a 2-year follow-up that shows its persistence as well, which is really great. Okay, see if I can wrap up in about 5 minutes here. We did another study on developmental trauma, and actually we have a webinar we did and slides from that on our website if you want to look at that and go through that webinar as well. But basically we looked at 40 subjects. They were randomized to to the coherence training versus a psychotherapy group. And basically the neurofeedback group did much better in the training. Their ratings were higher. Their therapist ratings were higher. They showed significant QEEG and connectivity changes and decreases in symptom tracking as well. We then did another study where we compared a lot of people talk about QEEG, and the people that sort of critique QEEG, especially QEEG guided neurofeedback, say, well, there's no evidence it makes a difference. And well, that's not entirely true. There is some evidence. There's not a lot, honestly. So this past year, we've done a study that we're in the process of publishing right now, where we looked at this question. So we looked at people that did this Granger causality affective connectivity measurement versus a functional connectivity coherence measurement that were used to design protocols. And based on those two different protocols, we measured the outcome. And basically what we showed is that the group that used this effective connectivity Granger causality model did much better than the group that used the functional coherence connectivity model. So remember, we talked about the way you look at it makes a difference. Well, not only does it make a difference in what you see in the data to understand their brain functioning, but it makes a difference in the outcome of their neurofeedback based on this study. And the group that had the effective connectivity used to plan their neurofeedback training had a better outcome based on the client's rating, therapist rating, and based on objective neuropsychological and QEEG data as well. Okay. So what have we learned over the past 20 years or so? And a lot of the research on the 4-channel in the past 5 years. Coherence training can be a very helpful form of neurofeedback for many different types of problems. Problems with connectivity-based issues appear to benefit the most. Those include autism, learning disability, depression, developmental trauma, seizure disorders, things of that nature. We actually are doing a study right now where we're doing a meta-analysis of these studies, which will actually tell us statistically which groupings respond better than others. So that'll be interesting to see what the results of that shows us. 4-channel multivariate coherence training appears more potent than 2-channel coherence training for multiple problems. This can be used to help with many different disorders and has a persistent effect, as we've seen in the depression study. The method used to calculate coherence and connectivity has a very large impact on what you see and the efficacy of the intervention. And measures of effective connectivity do seem to enhance the efficacy of the training. But there's a lot more to learn and a lot more work to be done, of course, in understanding people and how we can help them. So we certainly encourage anyone to try this that's interested, and even to do research on this, because there's a lot more to learn in different groupings and just understanding how these changes occur, which we still don't know a whole lot about. We know that the power in the EEG and power at source localized regions of the brain take place. We know that connectivity changes take place. The mechanism of that we don't always understand. So thanks for having me. I'd love to answer any questions. Our company is called Integrated Neuroscience Services. You can find our website at integrated-neuro.com. You can email me directly at Dr. Coben at integrated-neuro.com. And I'm happy to answer any questions or help you with any of this if you're interested. And as I said on the website, there's lots of other articles, previous presentations. You're always welcome to have free access to that. And I'll just put in a little shameless plug because Rob gave me the opening for this. My wife and I also do health coaching, which helps lots of people. And I'm sure, as most of you know, a lot of our clients deal with inflammatory, dietary, nutritional deficiencies. And these sorts of health programs and nutritional programs we work with are very good at aiding those programs. So if any of you are interested in this, you can reach us at robandann.healthcoach@gmail.com, or we have a Facebook, which is easy. Just look up Rob and Ann Coben, C-O-B-E-N, and you'll find lots of information about that there as well. Or if you contact us, we'd be happy to talk to you about that. So at this point, if anyone has any questions, they want to pose, I'd be happy to respond to those.
I guess, I don't know if Richard has unmuted everyone yet. We start to unmute him once you're done.
Okay.
So while we're getting people unmuted very quickly, because I want to give others a chance, there's a couple of theories I've understood about working with TBI. One is you can start doing neurofeedback, the next day, so to speak. The other is allowing the brain a period of time to sort of do its own natural recovery and healing process, in which possibly neurofeedback could interfere. Do you have a feeling about that or a thought about that one way or the other?
Yeah, I've not seen personally, clinically, any problem with starting neurofeedback very, very soon after TBI if you can do that. So I would encourage that.
All right. Others have questions?
Yeah, Dr. Coben, this is Martin Gremlich. Very quickly, how do you deliver the feedback? Audio, visual, or a combination?
So the feedback is the combination in the system we use. There's a visual feedback, very typically, as in most systems, in the form of a game or even a DVD video. And then there's audio that's heard or reward that you get through that as well. One of the things I do think that's very important if you're going to do this type of neurofeedback is that on your screen, you should have very discrete feedback. And what I mean by that is there should be an indicator on the screen. Let's say you're doing DVD feedback. There should still be an indicator on the screen, like a bar graph, that shows you your reward band and your inhibit separately, so the individual can learn to control them on their own and not just everything all at once. Because it's very different to learn how to control an amplitude than it is to control coherences. We do it in a way where you get auditory and visual feedback, and there are bar graphs that discretely display, so someone can pay attention to different features that they're doing training.
Like trying. Yes, and they learn what it feels like, what it should feel like if they're doing it right. Too, right?
Exactly.
Yeah. It's not so much about passive.
We'll try to mute that person. We'll give Richard a second to find him.
Okay.
All right, perfect. Other questions? We got a couple of minutes, folks.
This is Kimberly from North Carolina.
Hey, Kimberly.
Hi. Dr. Coben, it sounded like you said earlier that if we did a QEEG that we could send it to you and you could do some analysis with your software. Is that correct?
That is correct. It would have to be a full cap 19 channel EEG.
Yes.
But if you have data like that, we can certainly do that. So if you want to contact us with the location that's on the screen, we'd be happy to help you with that.
Great. Wonderful. Thank you.
Sure.
What kind of software do you use? Is it, you said you've got a few different, there's a few different platforms. Is that listed on your website?
I'm not sure that's listed anywhere, though. The one that we've always used is the Eager platform, and that's where this was initially programmed. But additional platforms have taken this up, so now the BrainMaster Avatar system can do this type of training as well. You can also do it in BioEra as well. And then the STENS system is programming this into their software right now as we speak, and it'll probably be ready in a few weeks to be used on that platform. And any other platform is welcome to program it. It's not very complicated to do so. You just need to have access to a 4-channel amplifier and software that will run training like this.
Great. What was it, your personal email address at integrativeneuro.com?
So it's just Dr. Coben at integrated-neuro.
Thank you.
All right. I'll go another one real quick with you, Rob, here. I've been doing just, sort of traditional 4-channel training for quite some time, and I've always thought it to be, in many cases, much more beneficial than 2-channel, and it seems like it moved people along a little bit quicker as well, as you were indicating. And I'm just curious, outside of the covariant, coherence training, has that been sort of your observation that 4-channel training will move things along a little quicker than 1 or 2-channel?
Yes, absolutely. I don't think there's any doubt about that.
Okay, great. Good to hear. Folks, we have a few more minutes if anybody else has any other questions.
I noticed,
Rob,
some of
this is Gary. I was wondering, I asked you a few years ago, if 4-channel is better than 2-channel, what about more channels than that? Did I hear you say that you were doing 19-channel coherence training like this?
No, we do not do that. And we have not studied yet how this would change with more channels. So what I would do, and this kind of gets to Rob's question a little bit, I would caution you, this is just my personal and professional opinion. A lot of people do 19-channel training, they do Z-score training, or even Loretta training. The data that we've seen so far does not suggest that 19-channel training is a whole lot better than this, or even 2-channel training. So, but I think the type of training matters. So while I do think 4 channels is better than 1 and 2 channels, I do, I'm biased, but I do think having the coherence and having the multivariate calculation of the coherence is very important. So if you're using 4 channels or even 19 channels, and you're still doing coherence training between pairs, like happens in Z-score training, whether it's pairs on the surface or pairs at a source, there's still 2 channels. You're still going to get those errors we talked about in the calculations. So that is going to probably have some benefits and probably have some not so benefits. So they may all actually cancel each other out. I do believe if we could, and maybe someday we'll develop this or someone else will develop this, if there were more than 4 channels, but they could do multivariate coherence calculations, that could be an additional benefit, but obviously we'd have to study that.
And Rob, I didn't see ADD in your list of things this is good for. Is that because you haven't studied it, or it's more of an amplitude problem?
Yeah, so we have not done a specific study related to ADHD, although in our clinical practice and people we consult with, they certainly use it for ADHD. But we haven't done a study to see if it has greater efficacy. I think, I actually think it does, but there's a lot of approaches that help ADHD. So what most people do that work with us is they tend to try the regular stuff. And then when it doesn't work, they say, hey, can you help us? Because the regular stuff didn't do it. Keep in mind, the ADHD approach of doing theta beta training, SMR training, again, the sort of response rate is between about 60 and 75%. So you've still got a lot of people that aren't responding. You still got one of that, based on that research at least, 1 out of every 4 patients that don't do as well as you think they should. And from what we've seen, this reduces that dramatically. So you could choose to do it up front, or you could choose to do it for the people the other stuff doesn't work so well with.
Thank you.
Yeah, Rob, we have seen the paper that you and Corey and Martin did, and have certainly discussed it here, and had discussions around the fact that the literature is pretty clear that there's nothing about those particular sort of methods that are still being investigated that shows that they're even better, superior to traditional neurofeedback. So we thank you for that paper, certainly. And I think people are understanding that you need to have a good foundation in what you do before you get off into some of these other methods that and to be cautious about in the absence of research, thinking it's going to be somewhat better than, because it's not,
And,
it's not what the research is.
if I can jump on top of that,
Oh, please.
just to emphasize, you know, we've talked about this approach, and while we have research on it, and that's important for every approach in neurofeedback, it is more potent than other types of neurofeedback. And as it is new, if you're going to try this, or if someday you want to move in this direction, we highly recommend you do supervision and mentoring with someone who's done it before, because there are, you know, ways of doing it that are very important to learn about. And just like you've done with other types of training, you should get supervision for sure. And there
I
are,
agree.
Yeah, and there are many people besides ourselves that are doing this now. You can get that from them, and of course, we're happy to consult with you as well.
Yeah, well, that's good to know. I mentor people, but I clearly, when I mentor people, make it clear I'm working with 1, 2, and 4 channel training. If you want mentoring and Loretta and InfraSlow or other measures, then we'll help you find somebody who's very skilled at that. So that's good to know that you provide mentoring or have people in your organization that will do that. The other thing, just to emphasize it, because we're close to the end, is we too here spend a lot of time looking at the holistic health picture of people and talking about things like you are with your coaching. You know, the inflammation and dietary things and exercise and all the things that go into good holistic health, which will improve the quality of your neurofeedback versus maybe even work against it. So any quick last questions since we're at 1 o'clock? Anybody have a quick one for Rob?
I saw some, this is Nathan Hollenbeck, I saw some EEG lab screens. Do you use any EEG lab plugins or modalities to do the Granger causality analysis?
Very good question. It's all based on EEG lab. So all the data is processed in EEG lab. I didn't have time to talk about the process of how to do that. But it's all based on ICA procedures, which then takes you to the Granger causality calculation. That is a separate plugin entirely, but it's all fed through the EEG lab platform. So that's how it's all calculated.
All right. Well, thank you. Thanks, Nathan. Rob, this has been wonderful. I'm so glad that we were able to fit you in and you had the time to work with us and do this presentation. I'm sure there'll be a lot of good follow-up questions, not only here, but people will contact you. And again, we really appreciate your time.
All right, great. Well, thanks for having me, and thanks everyone for attending.
Thank you.
All right, everybody.
Thank you.
Appreciate it.
Bye.